Hi, all. My name's Dominic. I'm the genetic counsellor at St George Hospital, and I've been asked to come along today to talk to you about genetic testing during pregnancy. So genetic testing is available throughout pregnancy, starting with preconception genetic screening and IVF and pre-implantation genetic diagnosis, as well as multiple test options throughout pregnancy and even genetic testing after birth in the form of a newborn heel prick test. But today I'm going to concentrate on those genetic tests available in early pregnancy. So today we'll talk about first trimester screening, NIPT, prenatal diagnosis, and use a couple of case studies to illustrate the use of these tests. Little genetics refresher course. So we're all made up of these trillions and trillions of individual cells. And in all of our cells, we have all of our genes. And genes are made up of long strings of code, ATs, Gs, and Cs in a particular order. And we have about 24,000 genes in all of our cells. And all of these genes are tightly stored on these little units called chromosomes. And if we look down a microscope at any one of our cells, we'll see a pattern similar to this, which is 46 chromosomes in all of our cells. And they all come in pairs. So a pair of one, pair of two, pair of three, etc. 23 pairs, 46 in total. And the last pair determine our gender, with males typically an X and a Y and females typically two X chromosomes. And we get one of each chromosome from each of our parents. So 23 in the egg meet 23 chromosomes in the sperm and 46 chromosomes in all of our cells. We know as mums get older, there's an increased risk of having a child with a rare chromosome anomaly, and we can see how those risks change over time. So here's a graph of mum's age versus the risk of having a child with a chromosome anomaly. You can see for a mum at the age of 38 years old has about a 1% chance of having a baby born with a chromosome abnormality. And the most common chromosome anomalies being Down syndrome, 3 copies of chromosome 22, or 3 copies of chromosome 13, trisomy 13, or Patau syndrome, or 3 copies of chromosome 18, Edwards syndrome. They're the most common chromosome anomalies. And so there are tests available throughout pregnancy to detect babies at risk of chromosome anomalies. The first being first trimester screening, which I'm sure you're all familiar with. It's been around for a long time now. So this is a screening test, testing specifically for those common chromosome conditions, trisomies 13, 18, and Down syndrome. It's a combination of mum's age and an assessment of ultrasound markers and a blood test from mum. The ultrasound is typically done between about 11 and 13 weeks in the pregnancy, and the results are returned as an odds ratio, so a 1 chance in something of having a child with a specific chromosome anomaly. And a high risk or an increased risk is defined as a risk that's greater than 1 in 300. Probably the most important ultrasound marker in this test is the nuchal translucency measurement. So all babies have a fluid-filled space at the back of their neck, a nuchal translucency, but we know babies with Down syndrome have bigger NT measurements in early pregnancy. And you can see there on the graph on the right, the distribution of NT measurements for Down syndrome babies against unaffected pregnancies. Another important ultrasound marker is the fetal nasal bone. So we know the presence of a nasal bone certainly doesn't exclude the baby having Down syndrome, but the absence of a nasal bone at 12 weeks gestation significantly increases the risk for fetal Down syndrome to about 20-fold. So a mum who would have otherwise received a 1 in 1,000 risk, if when they're not able to see baby's nasal bone at 12 weeks gestation, that risk is then amended to a 1 in 50. Another important component of this test is a blood test from mum looking at 2 placentally derived hormones in mum's blood, beta-HCG and PAP-A. We know that Down syndrome babies have a very characteristic pattern of these hormones in early pregnancy with raised beta-HCG and low PAP-A. And babies with trisomies 13 and 18 tend to have low beta-HCG and low PAP-A. So all that information is fed back into a computer algorithm with mum's age. So nuchal translucency measurement, nasal bone assessment, and blood test results, and then the results are given as a 1 in something number. And we know that this test performs very well in detecting babies with Down syndrome, in that about 85 to 90% of all Down syndrome babies will receive a high risk result on first trimester screening. So that probably equates to about 5 to 10% chance that a Down syndrome baby will receive a low risk result. So it's screening. It does, however, have a relatively high false positive rate, which was quoted at about 5%. So that's 1 in every 20 pregnancies that undergoes first trimester screening receives a high risk result, and the baby doesn't have a chromosome anomaly. And we know it has a relatively low positive predictive value. That is, how often is a high risk first trimester screen as a result of baby having a chromosome anomaly? And that falls out at about 10%. But what I thought was quite interesting to mention also is that the false positive rate increases significantly with maternal age. And you can see that graph on the right. So yes, it's about a 5% false positive risk for a mum, false positive incidence for a mum at the age of 25, but as you can see, you get older, the false positive rate increases significantly. And that's because the risk is very much determined and weighted to maternal age. So it's very hard for mums of late maternal age to get low risk results as a result of that. So you can see a mum at the age of 40, the false positive rate is probably running at about 30%. So a mum at the age of 40 years old has about a 30% chance of receiving a high risk result in a pregnancy when the baby doesn't have a chromosome anomaly. So onto the newer type of test, non-invasive prenatal testing, or NIPT. This is a blood test for mum. It's typically done after 10 weeks in the pregnancy. It's testing, again, screening for those common chromosome conditions, trisomies 13, 18, and 21. But in addition to that, also able to look at the baby's sex chromosomes, so whether the baby's XX or XY, so it can very accurately determine fetal gender, but also pick up on babies that have sex chromosome anomalies, for which there are several. Most NIPTs are limited to those common aneuploidies, and as we've talked about, can also pick up sex chromosome differences, which are milder genetic conditions than trisomies 13, 18, and 21 typically, and can pose a challenge in counselling regarding those results. There are different types of NIPT offered by different providers, and more recently there's a move towards genome-wide NIPT, so not just testing those common chromosome anomalies, but looking at all the fetal chromosome changes. So how does it all work? So it's a blood test from mum. Most of mum's DNA is trapped in her cells, but there's a small amount of cell-free DNA that's maternal in origin. But there's also an amount of cell-free DNA that comes from the fetus. So as the placenta breaks down, it leaks little bits of baby's DNA into mum's circulation. So all of that DNA in mum's circulation that's not trapped in her cells is a mixture of both fetal and maternal DNA. And what this test does effectively is amplify up all of the fragments of free cell DNA. And if there's too many of one particular chromosome in those fragments, then it's given a high risk call for that particular chromosome anomaly. So you would imagine if a baby had Down syndrome, that baby has a whole extra copy of chromosome 21. Therefore, there are an increased number of chromosome fragments originating from chromosome 21 free in mum's circulation. And so they're able to amplify up those fragments. And if there's too much of chromosome 21, then the test is called high risk for Down syndrome. So how well does this test work? Well, we know that it is incredibly accurate in screening for Down syndrome and those common chromosome conditions. And here is a study looking at 1.8 million women in China and the detection rate for Down syndrome. So for those mums in a high risk group, i.e. of late maternal age, the positive predictive value of a high-risk NIPT for Down syndrome runs at about 75%, And remember, the positive predictive value on first trimester screening for Down syndrome, probably closer to 10%. So that means that if a mum receives a high risk for Down syndrome on NIPT, it's much, much more likely to be real than it is on first trimester screening. But important to note there that that's 75% and not 100%. So a mum that receives a high risk result for Down syndrome on NIPT, that's not a diagnosis. That's a mum at high risk that needs to be offered further testing to confirm that. And you can see in that high risk group, the positive predictive value for trisomy 18, closer to 50%, and trisomy 13 closer to 30%. So this test performs very well for Down syndrome, less so for trisomy 18, and less so even still for trisomy 13. And there are complicated reasons for that. And we can see in that low risk group as well, which is probably most mums that you see, positive predictive values at sort of 60%, 35%, and closer to 10% for trisomy 13 in that low risk group. So that's a mum not of late maternal age who's not at increased risk for having a baby with a rare chromosome disorder. So that's relatively low. So performs well for Down syndrome and less so for the other common chromosome conditions. There is a picture of a karyotype with chromosomes 13, 18, and 21. Not sure why that slide is there. So I thought I'd touch on also the new types of NIPT. So these are NIPTs that screen not just for the common chromosome conditions, but for those other chromosome conditions. That's why that slide is there. It's just in the wrong order. So whereas the first forms of NIP tested for those common chromosome conditions, 13, 18, and 21, the newer types of NIPT are able to screen for other chromosome conditions. So where the baby has 3 copies of chromosome 7, for example, or 3 copies of chromosome 16. So whereas the older tests would have missed that, the newer tests can pick those up. And you can see from this graph, this is a pie chart representing all those screen positives in a relatively large cohort published recently. So you can see probably 50% of all those screen positives were those common chromosome conditions, so trisomies 13, 18, and 21. About 20% were those sex chromosome disorders, so that's Turner syndrome or XXY syndrome or Klinefelter syndrome or XXX syndrome. So they're relatively common, much more common than we once realized. And these are now being detected in pregnancy with the advent of NIPT. And we can see that maybe 10 to 15% of those screen positives were made up of rare autosomal trisomies. So that's not the common chromosome conditions, but trisomy involving some other chromosome. Most of those trisomies are not viable in that they will cause early miscarriage, but not all. And they can also have relevance to pregnancy management. We can also see there that about 10 to 15% are copy number variants. So for those screen positives for the genome-wide NIPT, up to 15% are high risk for a rare segmental chromosome difference. So that's not a trisomy involving a whole chromosome, but maybe a partial section of an individual chromosome is missing or deleted. So that it makes up a relatively large percentage of all those screen positives now for NIPT. And these are chromosome changes that we would have missed on first trimester screening. These are chromosome changes that we would have missed on the conventional forms of NIPT that just test for the common chromosome conditions. And these are chromosome changes that might have significant relevance to baby's health and development. So how well does NIPT work? So we know that it's very accurate when it comes to chromosomes 13, 18, and 21, although the positive predictive value varies depending on the particular chromosome and the a priori risk of the mother. The negative predictive value is very high. So negative predictive value meaning how often does a mum with a low risk NIPT go on to have a baby with Down syndrome, say, for example, and that risk is very low, although the outcome data there is not always reported. So the true negative predictive value is probably not known for some of these tests. And there's certainly been a couple of case reports in our local area of Down syndrome babies being born to mums who had had low risk NIPTs. So again, this is a screening test. We know the test failure rate runs anywhere between about 1% and 3%. So that's the possibility that mum has a test and there's an unreportable result. And we know that the test failure rate increases with maternal BMI. And we also know that multiple test failures increases the risk that the baby has a rare chromosome condition. So if you see a mum who's had multiple test failures with no other known reason for that, that's probably a mum at increased risk and might benefit from referral to discuss the option of additional testing. The genome-wide forms of NIPT, that's these forms of NIPT that test not just the common chromosome conditions, but all those other chromosome changes are being assessed, but look to be running at around 70%. So that means that 70% of mums that get a high risk result for a rare chromosome disorder on a genome-wide NIPT that go on to have follow-up testing, it's a confirmed diagnosis. But there are certainly false positives and negatives with all forms of this test, and therefore can't stress enough how much this needs to be considered a screening and not a diagnostic test. I know decisions should really be made about whether to terminate a pregnancy based on a high-risk NIPT result alone. I thought I was also stress the importance of an early fetal anatomy scan. So we used to do first trimester screening with everyone, and that sort of doubled up as an early fetal anatomy scan because they were doing a scan for babies' NT and nasal bone. But now with NIPT, some mums are not being referred for that early anatomy scan because they're having their NIPT test instead, if you like. But it is recommended that all mums also be referred for an early anatomy scan, and probably around 13 weeks gestation is the most informative time to do that early scan. And here's just an example of what can be detected in that early fetal anatomy scan. So there's lots of major fetal anomalies that can be detected by ultrasound early in pregnancy, and they run at about 3%. So about 3% of all mums who have an early fetal anatomy scan, either a major ultrasound anomaly is detected or there's a miscarriage. So just a little plug to always remember to organise that early scan, even in the setting of a low risk NIPT result. So take-home messages for NIPT, very accurate for Down syndrome, less so for some of the other chromosome conditions. Certainly remains a proportion of false positives and false negatives. NIPT can be offered in combination with first trimester screening. So mums that receive high-risk first trimester screening results can then be offered NIPT result as long as there's no obvious reason to refer for prenatal diagnosis rather than NIPT, and I'll touch on that on my next few slides. NIPT comes in the form of either a test limited to those common chromosome conditions or more recently the genome-wide forms of NIPT. And I think most NIPT providers will switch over to a genome-wide version of the test within the next probably 6 to 12 months. And certainly consider referral for diagnostic testing, so CVS or amniocentesis, which we're going to talk about soon, rather than NIPT if there's any risk for some rare chromosome anomaly in the baby, and remembering that multiple test failures increases the risk for a fetal chromosome condition. So who should be offered invasive prenatal diagnosis over NIPT? This is a question I get asked commonly. So the most common reasons for referral for prenatal diagnosis include high risk results from either first trimester screening or NIPT, or certainly if there's any structural abnormality detected on ultrasound, that's a mum who would benefit from referral for a discussion around the option of prenatal diagnosis rather than NIPT. Babies with bigger nuchal fold measurements, greater than 3 millimeters, say, for example, on first trimester screening, should be offered referral for prenatal diagnosis rather than NIPT, because those fetuses are at much higher risk for chromosome disorders. Mums of late maternal age should really be offered the option of prenatal diagnosis, knowing that the a priori risk for a mum at the age of 40 is double that of a mum at the age of 20. And certainly all pregnancies that are at increased risk for a genetic anomaly not detectable on NIPT. So remember, NIPT detects the common chromosome conditions, but it doesn't test all of the baby's genes. So say if you have a couple who are at high risk of having a baby with cystic fibrosis because they're known genetic carriers, they need to be referred to discuss the option of prenatal diagnosis, because you wouldn't be able to detect a baby with cystic fibrosis with NIPT. That can only be detected with prenatal diagnosis. So practical advice for patients: if a normal NIPT at 10 weeks, then refer for a 13-week ultrasound without nuchal translucency assessment. So sometimes mums get low risk results, are referred for a fetal anatomy scan, and then they end up getting a whole other Down syndrome risk assessment, which is unnecessary. And all that really does is increase the false positive rate without perhaps increasing the detection rate. If a high risk first trimester screening, you can consider referral for an NIPT if there's no other risk factors for atypical chromosome anomalies. That is, there's no structural anomaly in ultrasound. This isn't a baby with a very large nuchal fold measurement, or it's not a baby at increased risk for a single gene disorder. And refer patients for prenatal diagnosis if the couple are requesting prenatal testing, prenatal diagnosis rather than prenatal screening, if there's a very high first trimester screening result, or if mums are at significantly increased risk based on their age or an ultrasound anomaly. So to the prenatal diagnostic procedures, so first of which is chorionic villus sampling, or CVS, and this is typically done between 11 and a 13-week gestation, and this is a test typically transabdominally, which is sampling the placenta, and typically the chromosome composition of the placental cells is the same as the fetal cells, so it's effectively testing the chromosome composition of the fetus. And as it's an invasive procedure in early pregnancy, there's an increased risk of miscarriage associated with this testing, which is probably at around 1%. So a 1% chance of miscarriage associated with this test. Amniocentesis testing, similar to CVS, however, done after 16 weeks in the pregnancy. This is sampling of amniotic fluid rather than placental tissue. Again, increased risk of miscarriage, but less than that of a CVS, perhaps a 0.5 or 1 in 200% chance, or 1 in 200 chance of miscarriage based on this test. The results come back later, as this testing is done after 16 weeks gestation, so perhaps results back 17, 18, 19 weeks gestation. And typically, if there's a chromosome anomaly detected at this stage in the pregnancy and the couple choose to terminate the pregnancy, that would likely require an induction termination of pregnancy rather than a surgical termination of pregnancy, which might be possible if a chromosome anomaly is diagnosed via CVS earlier in the pregnancy. So what's the difference between these two tests? So it's amniocentesis associated with a lower risk of miscarriage. Results for CVS, however, typically back before 14 weeks gestation rather, whereas amniocentesis results back after 16 weeks in the pregnancy. You see more anatomy under ultrasound at the time of an amniocentesis. There's also this possible complication of placental mosaicism. So sometimes the placental chromosome composition is not reflective of the fetal chromosome composition. So you can get this state in which there are abnormal cells in the placenta that aren't there in the baby, which means that you can get false positives on a CVS. So you could get a CVS result showing an abnormal chromosome composition, whereas that might not be true of the fetus. So it's a technicality, and it's true of some chromosome conditions more so than others, but not so much Down syndrome. So Down syndrome babies, confined placental mosaicism is very rare, but there are other certain chromosome conditions for which confined placental mosaicism risk is higher. And I'm thinking of some of the sex chromosome anomalies as well. But technically, amniocentesis testing is a sample of the fetal cells that are derived from the fetal bladder and fetal skin and the membranes that make up the amnion, so perhaps more reflective of the fetal chromosome composition. CVS is technically a more difficult test to do, and so that's probably part of the reason why it's associated with a higher risk of miscarriage, although the disadvantage of amniocentesis being later diagnosis. So what testing do we do on CVS and amniocentesis samples? So we used to do a chromosome analysis, which is effectively counting the baby's chromosomes, testing for those common chromosome conditions, and seeing if there's any other additional or missing chromosomes in the baby. But more recently, we've moved to array-based testing, which is testing for submicroscopic changes on individual chromosomes, so small deletions or duplications on any of these individual chromosomes. And I think our current arrays are running at about 800K, which means there's 800,000 probes covering all of the fetal chromosomes, so it's able to detect very small changes in individual chromosomes, small deletions and small duplications. And even though they're small, they might still have they might still be associated with significant genetic anomalies in the baby. So our yield on testing has increased as a result of moving to the array-based test rather than standard karyotype testing. But I suppose with all types of testing, increased detection also leads to a higher chance of finding a variant that's uninterpretable or that has very little information available about it, which can present a challenge in counselling couples. So array testing has a much higher yield than standard karyotype testing, and is able to detect about 10% more chromosome anomalies than standard karyotype testing alone. And then, as I mentioned, there's a chance of finding a change in a chromosome, the phenotypic relevance of which is uncertain. It can also lead to incidental findings, and it will miss structural rearrangements like translocations, but it's a better test than karyotyping. More recently, we haven't moved from, but we have the option of additional genetic testing on CVS or amniocentesis samples in the form of whole exome analysis. So whereas array and karyotype testing are essentially looking at the chromosomes, so big picture look at baby's genetics, whole exome testing is able to examine individual genes. So imagine there are 24,000 genes distributed amongst all of these chromosomes, and all of those genes are made up of ATs, Gs, and Cs, long strings of code. Whole exome testing is able to examine the sequence of some of those individual genes. So essentially reading the code to see if there's any spelling mistakes in the gene that might cause a genetic anomaly. Whole exome analysis is limited to about 5,000 genes, and those are the genes that have been directly implicated in human genetic diseases. So it doesn't look at all of the baby's genes, it just looks at those genes that we know cause particular genetic diseases. This testing is very new, it's very expensive, it's very time consuming, and it's only offered in very specific settings, and typically where there's multiple anomalies detected on ultrasound and the baby has a normal array, then we might consider the option of whole exome testing to test for some of these rare single gene disorders. It's typically done as a trio in testing the fetus as well as the mum and the dad, because there's lots of natural genetic variation in our genome, and it's very helpful to have mum and dad's DNA as a control to understand what variants have been inherited versus what are new genetic changes in baby and what therefore might be disease causing. Here's just a recently published article on the diagnostic yield of exome sequencing versus the conventional array and karyotype testing. So we know that there's, in the setting of a skeletal anomaly, you've perhaps got a 50% greater yield on exome testing above that of standard array and karyotype testing. So that's a significant number. In the setting of multiple anomalies detected on ultrasound, perhaps an additional 30% yield on exome versus array testing. In the setting of an isolated cardiac anomaly, perhaps about a 10% increased yield above that of standard array testing. So you can see that this technology has the potential, has the possibility of picking up much greater numbers of genetic anomalies beyond that of standard array testing. So I suppose I consider it So sorry about that. We always start our testing with a standard array, looking at the baby's chromosomes, and then think about the option of exome testing if the baby's, and if the array testing is negative, think about the option of exome testing if the baby's at increased risk for a rare single gene disorder. So a couple of case studies to round off, guys. Here's a 34-year-old mum in a second pregnancy, having had one miscarriage previously. She'd had a normal NIPT at 11 weeks gestation, and she had a early fetal anatomy scan at 12 weeks, and baby was found to have a 6 millimeter nuchal translucency measurement. And probably the normal measurement of that gestation is around 1 to 3 millimeters. So this is a baby with a significantly abnormal NT measurement. She was referred to our service at 13 weeks gestation for further counselling regarding the limitations of NIPT, the increased risk for a rare atypical chromosome disorder not detectable on NIPT, and discussed the option of CVS and amniocentesis testing. She elected to proceed with CVS testing, and on the array, baby was found to have a deletion on the short arm of chromosome 5. And this involved the critical region that causes this particular condition, Crudeshar syndrome. The severity of this condition is somewhat dependent on the size of the deletion, but it's characterized by dysmorphic facial features, microcephaly, usually severe intellectual disability with behavioral disturbances. It's typically de novo in that it's not an inherited chromosome change. It's a new chromosome change in the baby, not inherited from mum or dad, but up to 10%, 10 to 15% is caused by parental chromosome translocation. So the outcome of the pregnancy, the couple decided to terminate the pregnancy. We tested the parents' chromosomes and they were normal, so we excluded a translocation as a cause. So this was likely a de novo or one-off chromosome change in that fetus, and therefore associated with a low recurrence risk at about 1%. That 1% risk due to possible germline mosaicism, so there being a small pocket of egg or sperm cells that carry that deletion but don't make up the bulk of the parent's chromosomes. The couple were reassured by the low risk recurrence, and they had the option of prenatal diagnosis in the future pregnancy just to test to make sure that any new baby didn't have that same chromosome 5 deletion. So I suppose the learning outcome in this being that, not all chromosome disorders are detectable on NIPT, and certainly this was missed on that conventional form of NIPT, just testing for those common chromosome conditions. However, this is a chromosome deletion that may have been picked up on the newer forms of the NIPT, the genome-wide forms of the NIPT that screen for all of the baby's chromosomes. And the reason that this couple were referred for prenatal diagnosis rather than another NIPT test was the large NT measurement. So that was the right decision. So another case study, this is a mum in a second pregnancy, 32 years old, had a healthy daughter. She was referred at 12 weeks gestation after having first trimester screening, and baby found to have a 3 mil nuchal translucency. She had a low risk genome-wide NIPT this time. So that's not just testing for the common chromosome conditions, but testing all of the baby's chromosomes. The couple had declined prenatal diagnosis, so CVS or amniocentesis, pending their fetal morphology scan, because this was a baby with a 3 millimeter nuchal with a low risk NIPT. So probably chances are this is a normal baby with an increased NT. However, the couple had their morphology scan and baby was diagnosed with a ventricular septal defect and a unilateral multicystic dysplastic kidney, and counselled at the time regarding the increased risk for a chromosome condition, and also a single gene disorder based on those multiple ultrasound anomalies. So an amniocentesis was performed at around 20 weeks gestation. The array result was normal. So that's that detailed chromosome study of the baby. That was all normal. But based on the multiple ultrasound anomalies, couples were offered trio exome testing, which found a mutation in the KMT2D gene that was found to be de novo in that it hadn't been inherited from either of the parent and was a new genetic change in the baby, and therefore consistent with the diagnosis of fetal Kabuki syndrome. Kabuki syndrome is a developmental disorder characterized by distinctive facial features, growth anomalies, skeletal anomalies, and typically mild to moderate intellectual disability, and congenital abnormalities of the kidney and urinary tract, hearing loss, and cardiac defects. So that was consistent with the ultrasound findings of multicystic dysplastic kidney and a VSD. So again, the couple made the very difficult decision to terminate the pregnancy. This was a difficult decision for the couple because the phenotype, the condition itself, can be quite variable, and yes, usually associated with mild to moderate intellectual disability, but actually some kids do quite well and probably have mild intellectual disability rather than moderate intellectual disability. So it was a difficult decision for this couple. It was a de novo mutation, so that meant low recurrence risk, 1% or less in any future pregnancy. She's actually pregnant again, and because of the low recurrence risk, had declined CVS or amniocentesis based on the increased miscarriage risk. But on her 20-week fetal anomaly scan, baby was found to have a minor kidney difference. And as you might have imagined, that made them very anxious about the possibility of a recurrence. They requested an amniocentesis at 20 weeks, and we were able to test the new baby for that genetic variant found in the previous pregnancy, which was negative. So we knew that new baby didn't have that same variant, so it was at low risk for Kabuki syndrome, and the couple were very reassured, as you might imagine, as a result of that. So the learning outcome here being that even in the setting of normal NIPT and normal array, there's still an increased risk for rare single gene disorders not detectable on NIPT for babies who have multiple structural anomalies. And now we have the option of exome testing for those babies. And we know that we have a significantly increased yield, i.e. the chance of finding a significant genetic anomaly in a baby with multiple structural anomalies on an exome. I think I'm running out of time, guys, but I just thought I'd touch briefly on the advances in preconception screening. So there's a recommendation that all couples planning a pregnancy be offered preconception genetic screening, and that can be targeted based on ancestry. So we know that couples of Northern European background are increased risk for cystic fibrosis, so might be offered cystic fibrosis carrier testing, or those mums from, or those couples of Middle Eastern or Ashkenazi Jewish descent are at increased risk for other recessive disorders. I think all couples, it's recommended that they be screened for thalassemia, but particularly those of Southeast Asian, subcontinental or European Europe. But there's lots of now, or there's these big preconception genetic panel tests that can be done that can test couples for up to 500 of these rare recessive disorders. And in November this year, I've been led to believe, Medicare will now cover a version of this test, testing for three of the most common recessive disorders, being Fragile X syndrome, cystic fibrosis, and spinal muscular atrophy. I should clarify, Fragile X syndrome is not a recessive disorder. It's an X-linked disorder where mums can be silent carriers for Fragile X syndrome. And it's the most common cause of inherited intellectual disability, with an incidence of about 1 in 3,000 males, typically only affects males. And then those two more common recessive disorders of cystic fibrosis and spinal muscular atrophy. So hopefully as of November, you can order preconception genetic testing for these common conditions on all your couples, and it be Medicare rebated. So I think I've run out of time, guys. There's always lots more to talk about when it comes to genetics, and I'd be certainly happy to give talks on other aspects of prenatal genetics, but I thought I'd leave it there for today. Thank you for your time. Bye.